All right, I think we will get started. Good afternoon, everybody, and thank you very much for joining us today during your lunch hour. My name is Sonia Kantek, and I'm the Manager of Medical Practice Affairs here at the California Academy of Family Physicians. At CAFP, it is our ultimate goal to make sure that you have the most timely and useful information to you to help navigate the quality payment program's complex requirements and to realize what resources are available to you. It's been our priority here specifically to identify how the rules apply to you and to clarify them. I encourage you to continuously check out our website throughout the year at www.familydocks.org/QPP. This website is a section of our main website which gives you information and is constantly developing new resources to help you. Before we get started with both the presentations, I want to call your attention to the chat function. The chat function is located at the bottom of your screen. There's an icon with a speech bubble, I believe, that says chat. If you click on it, a text box will appear, and you are welcome to place in any of your questions throughout the webinar. We will be responding to all of them and addressing to as many as we can at the end of the presentations. If something is pertinent and applies to what's being talked about, we may address it at that time, but most likely it'll be at the end of the presentation. This presentation will also be made available on the website, both the recording and the PowerPoint slides, and should also be sent out to you by the end of this week. So without further ado, I'd like to introduce our two presenters. We have Leah Newkirk, our health reform and payment expert, and David Mitra from the Health Services Advisory Group. Leah will focus on giving a summary of the QPP and MIPS programs and walk us through a description of some special issues for the small and rural practices, while David will then focus particularly on available technical assistance through HSAG. Thank you again so much for joining us, and Leah, if you'd like to go ahead.
Good afternoon, everyone, and thank you for that introduction, Sonia, and thanks to everyone for joining today's webinar on the Quality Payment Program. And today, of course, we're offering guidance specifically to CAFP's small and rural practices. So this is me. I am a consultant with LSN Health Strategy, but also a former CAFP staffer, and I'm very happy to be continuing my work with CAFP and providing this kind of educational programming on the Quality Payment Program. So my email and phone number is listed here, and it's at the end of my slides too. I welcome any questions from you about this material. I know CAFP does too. Next slide, please. My goals for this webinar today are to provide, as Sonia said, an overview of the Quality Payment Program, but also to discuss what we view as special considerations for small and rural practice physicians, and then finally to describe additional available resources. Before I turn the program over to Dave, who will describe what I think is the most important resource available to you today, and that's free technical assistance for small and rural practices. So he'll describe that in some detail. And one of our main goals today is to send you off to contact Dave and the Health Services Advisory Group about how they can help you. Next slide, please. But we always want to emphasize CAFP's mission, and that's to ensure that family physicians in every kind of practice setting thrive in California. But having looked carefully at the pretty complex quality payment program, we recognize that small and rural practices face unique challenges when it comes to this program and the general movement towards value-based payments. So we know we need to offer tailored assistance to you, and this webinar represents a piece of that. But again, we need your feedback. We need to hear from you about what your needs are. So we always welcome, you can contact me, you can contact Sonia at CAFP and let us know how we can help with all of this. Next slide, please. So the Quality Payment Program comes from a law called the Medicare Access and CHIP Reauthorization Act of 2015. And it's important in this crazy political age to differentiate this law from the Affordable Care Act. I know in the news you're reading about the American Health Care Act in the Senate secret meetings. That is a very separate law from repeal and replace is very separate from MACRA. And MACRA is not a target for change by the new administration or Congress. So as far as we know, MACRA and the Quality Payment Program is here to stay, and we need all of our California family physicians thinking about this and how to prepare for it. So MACRA has two goals that we want to emphasize today. One is to move the Medicare program towards value-based payments and away from fee-for-service. They basically want to reward you for high-quality, low-cost services as opposed to the number of services that you offer. It also, and this is important as you dive in and feel kind of burdened by the measurement and reporting, it did a pretty great thing in getting rid of the Sustainable Growth Rate Formula, or SGR. So we celebrate MACRA for doing that. The SGR threatened Medicare payments by 20 or 30% year after year. This law got rid of that. So we're happy to see that. It did many other things, including reauthorizing the Children's Health Insurance Program and some other important things too. But today we're going to focus on the Quality Payment Program. So next slide, please. So historically and today, this is how Medicare payments are structured in Part B. You provide, as a clinician, as a doctor, a service. There's the Medicare fee schedule, and you're paid according to that schedule for your services. But along the way, that payment is adjusted by these different programs. PQRS, the value-based payment modifier, the Medicare EHR incentive program, which you might know as meaningful use. So there's all these different adjustments made that gets to your final payment. Next slide, please. And this is what MACRA does. You're still a doctor providing services. We still have a Medicare fee schedule, but the Quality Payment Program is this one adjustment to your payment before you get to that final calculation, the final payment. And as you may have heard, the Quality Payment Program is split in two. We've got the Merit-Based Incentive Payment System, or MIPS, or the Advanced Alternative Payment Models, or APMs. And you're on either one or the other of these tracks. Next slide, please. And who's included? Who's eligible for this program? The basic answer is Medicare Part B clinicians. And those clinicians include family physicians, or all physicians, physician assistants, NPs, clinical nurse specialists, certified registered nurse anesthetists. There are some exemptions, though, and an important one is here, and we're going to reemphasize this later in the webinar, called the low volume exemption. So if you bill, you have to bill more than $30,000 a year in Medicare charges and provide care for 100 or more Medicare patients in a given year to be eligible for this program. Next slide, please. Now, MIPS is one pathway you can take in the QPP, the Quality Payment Program. MIPS is a modified fee-for-service model, pretty similar to what you're used to, and we're going to emphasize MIPS going forward in this program. The other track you can potentially get on is called Alternative Payment Models, or Advanced Alternative Payment Models. And the real distinction is that APMs are groups that take on some financial risk. They tend to be really large groups. but they're a special subset and they are exempt from MIPS. So there are 712,000 clinicians who are projected to be a part of the quality payment program. The vast majority are going to be in the MIPS program. Only 10 to 15% will be in advanced alternative payment models. And if we take a look at the next slide, these are the advanced alternative payment models in this first year of the program. And the top 3 listed here in bold are really the only programs that include family physicians. And then another note, we don't have comprehensive primary care plus in California, so you're not in that one, despite CAFP's heroic efforts, I think, to get that program in California. We don't have it yet. So you have to be, as a California family physician, in the Medicare Shared Savings Program, Track 2 or 3, or in a next-gen ACO model to be an advanced APM. And these are big groups. So the vast majority of small and rural practices are going to be in MIPS, and that's going to be, I think, Dave and my emphasis going forward. Next slide, please. This is just another way of looking at this. You're in MIPS as a default. If you're not in one of those APMs on the short list, even if you are in an advanced APM, you have to be a qualified provider in an advanced APM to pull you out of MIPS. And that just means that enough of your payments or patients are flowing through the advanced APM to get you into that category. Next slide, please. So there is now a MIPS eligibility lookup tool that kind of cuts through all of this confusion and can tell you, are you in an advanced APM? Historically, do you fall into that low volume exemption? And so we would ask all of you to go to the CMS CPP website, cpp.cms.gov. The URL is on this slide, but I noted today that it's also on the home page. So just cpp.cms.gov, and using your national provider identifier, look up your status in this program, and you can tell whether you are a MIPS physician or fall under some exemption. You were also supposed to have been sent a letter from Meridian Healthcare Solutions in May. Meridian is the MAC that kind of covers California in the Medicare program and is there to assist you with some questions about this too. If you did not receive a letter from Meridian, I think the first place to go is this lookup tool, but you can contact Meridian at 855-609-9960 and write to me if you need that information again and learn more about your eligibility for MIPS. Next slide, please. So MIPS changes payments for physicians and other eligible clinicians in 2019, but it is based on your data in 2017, this year. So there's some urgency to all of this. We really want folks paying attention, starting to think about their strategy for reporting, because 2017 is the first performance year in MIPS. Now you can see that MIPS adjusts your payment upwards or downwards, and in the first year it's up or down 4%, but it goes up from there and will have a bigger influence on your payments over time. Also want to note that there's a $500 million available for what are called exceptional performers in the MIPS program. The top 3/4 of those who receive a MIPS adjustment will get an added bump in this program. Now, in the APM program, it's just an automatic 5% bonus over time, but again, it is based on your status 2 years earlier. So 2019 is based on, are you in an advanced APM? Are you a qualified provider in 2017? Next slide, please. Now, when CMS published the regulations on MACRA, there was a real push from stakeholders, and that includes CAFP, to really slow the start of this program. We're very concerned about the effect of this on small and rural practice family physicians. So we pushed, and what we got was a slower start, in the sense that there's a lot of flexibility for reporting in this first measurement year of 2017. And physicians who report any data for 2017 can avoid that negative adjustment. So these are the options. You can test the program, and I'll talk more about what that means. You can participate fully for 90 days, or you can participate for the full year. If you don't do any of these things, you get an automatic negative 4% adjustment. So strongly encouraging everyone to participate in some way. And as we'll discuss, there are very achievable ways of testing this program. Next slide, please. So if you start to think about your strategy with all of this, you should note that you can, in the MIPS program, report as an individual physician, or you can report as a group. And a group is defined as a set of clinicians who have different national provider identifiers who share a common tax identification number. So if you're in that situation, even if it's a small group, you have to decide strategically, do we want to participate as a group, or do we want to report as individuals? And you really just need to think through whether you want payment adjusted based on your individual performance or based on an averaging out of the group's performance. Next slide, please. And in these next couple slides, you'll see that another strategic decision you have to make is how you're going to report. What mechanism are you going to use to report? And this varies for individuals versus groups. And it varies based on the 3 performance categories that are measured in 2017. But want to note that if you're reporting as an individual, there are options that include claims and administrative claims. So if you don't have an EHR yet, you can still report in this program in this first year. Groups have some special options, and I want to note one on this list. The CMS web interface is available for group reporting. However, you need to register that, and the deadline is coming up very soon. It is June 30th that groups need to register for the CMS web interface. So next slide, please. You'll see again in other performance categories the mechanisms that are available for reporting, and you'll get the slide set. 2 points of emphasis again, that there are ways to report that don't have to involve an EHR, and that as a group, if you're reporting, you need to register for that CMS web interface very soon. Next slide, please. And this is my last slide in the overview of the QPP, but it's an important one. So in MIPS, you will be measured in 4 performance categories to get to what is called your composite performance score. That's your overall score that leads to your payment adjustment. However, in this first year, in 2017, they're not measuring cost. So you can take that out of the equation. And if you look at that little box on the lower right-hand corner, in 2017, quality is weighted most heavily. It's going to be 60% of your score. Advancing care information is 25% of your score. And improvement activities are 15% of your score. I also want to note that 3 of these performance categories align with current programs. So quality pulls from the PQRS program, costs from the value-based modifier, and advancing care information is this new way of describing meaningful use. So those programs don't go away entirely, but on the plus side, if you have some experience reporting PQRS or meaningful use, you have kind of an edge in this program, and it should ready you for this program in a lot of ways. Next slide, please. Can you move forward in my slides a little, Sonia? I think I'm kind of off here. Oh, this is, okay, keep going. Yes, this is where I want to be. Thank you for that. So some special considerations for small and rural practices that we want to go through. And I want to first define small practices. Under this law, they're generally those that have 15 or fewer providers. Rural or health professional shortage area practices are also in this category with some special treatment under the law. So we'll go through these one by one. Next slide, please. So for this audience, we wanted to place special emphasis on this exemption. Again, if you bill Medicare $30,000 or less, or if you have 100 or fewer Medicare patients a year, you're exempt from MIPS. And if you're in this exemption category, you still are billing Medicare, you just don't have that QPP adjustment to your payment that gets to the end, your final payment calculation. And we're anticipating that many small and rural practices will fall under this exemption. So we again encourage you to use that eligibility lookup tool today and figure out where you are. Next slide, please. Another point of emphasis for small and rural practices, and we appreciate that this program can be overwhelming, and this may seem quite burdensome for all physicians, but particularly for those who don't have staff necessarily to devote to focusing on this. But we want to emphasize that in this first year, there's a lot of flexibility, and you do have options that are achievable. So when we say that you can test the quality payment, you can test the MIPS program in this first year, that means that you can submit one quality measure or one improvement activity or 4 or 5 advancing care information measures, and you can avoid the payment penalty. So really urging small and rural practices to consider these options that we view as achievable. And again, that quality measure or that improvement activity, you can report through claims data. You don't even need to have an EHR to meet this requirement. So urging everyone to consider these options. Next slide, please. Now, I'll point you to this in later slides, but CAFP has a new and wonderful primer for small and rural practice physicians available on CAFP's website. And in that, CAFP's Medical Practice Affairs Committee suggests some achievable measures for your consideration. So some quality measures for you to think about. Among, there are 270 quality measures overall. Selecting from those, CAFP's Medical Practice Affairs Committee suggests maybe 10. I also want to note that CMS has a new document on its website called MIPS Measures for Primary Care Clinicians, which is kind of similar. It's a non-exhaustive sample of measures that apply to primary care in their view, and about 10 quality measures, about 12 improvement activities that they suggest you can choose from. And again, you just have to choose one quality measure to avoid a penalty, or you just have to choose one improvement activity to avoid a penalty. Next slide, please. And CAFP and other stakeholders fought for reduced requirements for small and rural practices, and in some places, CMS complied. So in the improvement activity performance category, most MIPS clinicians, when we get past this first year of flexibility, will have to report on 4 improvement activities, whereas going forward, MIPS clinicians in small, rural, or health professional shortage area practices only have to report on 2 improvement activities. Next slide, please. There's also special considerations for rural practices in areas of limited internet connectivity, and we know that some of our California practices in our rural areas will fit into this category. So if you are in a place where there's limited internet connectivity, CMS says, okay, you don't need to report on advancing care information or this new meaningful use category. Instead, we're going to reassign that 25% to the quality performance category. So we're really going to emphasize for you quality. It's going to be 85% of your overall score, and you don't need to think about advancing care information. Next slide, please. But we note that if you are in this category, you need to apply to CMS for this reweighting. It's not automatic. If there are certain MIPS eligible clinicians who qualify for automatic reweighting, if you're a PA or an NP or a hospital-based clinician, or if you are a kind of doctor who doesn't have face-to-face interactions with patients, you're automatically reweighted. But if you're in this category of having insufficient internet connectivity, you have to apply, and we invite you to contact CAFP or me to learn. I can direct you to where you apply for that. Next slide, please. And this is just a flag for later, but there is an opportunity out there for small practices to be measured as a group going forward. It's called virtual groups. So you might group together in a region. At this point, CMS is not doing this. CMS is not permitting virtual groups in the 2017 performance year. So we don't have the rules, the regulations out on this. But when they do come out, CAFP and AFP will analyze what are the advantages and disadvantages to you to doing this, and we will let you know, but consider it in the future. Next slide, please. And so we want to focus on some additional resources that are available to you before we turn things over to Dave to talk about this great technical assistance that is available to you. The first resource I always advise people to visit is the CMS website, cpp.cms.gov. This is a great and very user-friendly place to get more information about the quality payment program. And I know most CMS websites are not user-friendly, and I would not direct people there, but this really is a great place to start. Similarly, CAFP's website on the quality payment program, familydocs.org/payment-reform, is a great place for more information on the quality payment program. And it's also the place where you can access the new primer for small and rural practices on the quality payment program. So again, get to that list from the Medical Practice Affairs Committee of suggested metrics. Additionally, a library of resources in there for you, so a great place to go to. Next slide, please. AFP also has its MacroReady site with some great videos and learning modules and additional information on the quality payment program. I haven't seen anything for small and rural practices specifically there yet, but a great place for background information at this point. Next slide, please. And we'll turn things over to Dave and the Health Service Advisory Group to talk about the free technical assistance that's available to you through their group. I also, in an earlier slide, there's a CMS Helpline that is mentioned. This is a great place to go to if you have specific questions about the program. I've used it. They respond in 24 hours and they're very thorough. So a great place for specific questions, not a great place to help you figure out what to do here. Dave and Health Services Advisory Group is definitely the place for that. Again, I invite questions here today, but also in the future. This is my contact information. You should feel free to contact me, and I will turn it over to Dave to discuss what they're offering. Thank you, everyone.
Sonia, do you mind forwarding my slides? Hi, can everybody hear me?
Hi, Dave. They should be able to. They're on mute right now.
Okay, perfect. So, excuse me. My name is Dave Devashish. I'm with Health Services Advisory Group. And for those of you that are not familiar with us or have heard about us, we are the Medicare Quality Improvement Organization for the state of California. What it means is that we are on contract with Medicare to provide no-cost assistance to providers to participate in various Medicare quality reporting and improvement initiatives, which includes the MIPS that Leah had a great job explaining. So I am going to skip over a couple of slides which kind of talk about MIPS because Leah has covered that, and go straight to what you need to do now. So Leah, as Leah explained, under the MIPS, there are three categories under which you as a provider have to report data: quality, ACI / meaningful use, and improvement activities. So very often now the question is, what next? What can I do to get there? Can we go to the next slide? Next slide. So realizing that CMS has a couple of contracts out that we hold in the state of California. One is the QIO, or the Quality Improvement Organization contract, under which we provide services to the Medicare providers in the state of California, Florida, Ohio, US Virgin Islands, and Arizona, which is our corporate headquarters. And under the QIN contract, we work in various settings of care, including physician offices. And this contract is specifically targeted at large organizations, which is defined as physician offices with 16 or more eligible clinicians. Then early this year, we have another contract from CMS, which is called the SURS contract, or the Small, Underserved, and Rural Service Providers. And under the SURS contract, we can service providers that need assistance between with clinicians in the range of 1 to 15 NPIs. Next slide. This just shows a reach of what HSAG does, 25% of the nation's Medicare beneficiaries. Next slide. We also have various state contracts, the ECRO and the HEDIS contracts in various states, and we cover almost 46% of the Medicaid population. Next slide. So this is what I already explained. We have direct technical assistance for California under 2 different contracts, greater than 16 under the Quinn contract, and less than 15 under the, or less than 16 under the QPP contract. The contracts are to provide specifically education and assistance to eligible clinicians. Next slide. Okay, so what we have is the services we provide include working with providers, number 1, to educate them about the MIPS program in details. And then number 2, on the quality side, you will be scored on the 6 quality measures that you would be submitting. And the thing to note here is that every data that you submit, every piece of data that you submit, quality, cost, not cost, quality, ACI, and improvement activities contribute to an overall quality score. Your quality score determines whether you will get a positive or a negative adjustment. So in order for you to be on the positive side, the idea is to maximize the quality score to the extent possible. How do you do that? The way to do that is to pick up the 6 measures that would maximize your returns, that would maximize the score you could do. So that is what we provide. We will help work with your staff and yourself to pick up the 6 measures that would potentially give you the maximum score with the least effort. We have developed an internal scorecard that when you plug in your measures, it will predict what is the overall score going to be. Next slide. As you know, that you have to report on 6 measures. Each of the 6 measures can potentially bring you between 3 to 10 points. And our services will be trying to help you not only select the measures, but improve your workflow, improve your documentation procedures so that you can maximize every quality measure that you submit. Next slide. This just kind of shows how the scoring is. So depending upon your score, so let's look at the first row here, which is preventive care screening for influenza. If you're submitting by claims, and let's say your percentage of the flu immunization is 50%, which if you look at the table is in decile 5, which means that you're going to get 5 point something in your score. If your score is, let's say 70%, you will be in decile 7, which means that your score would be in the range of between 7 and 8. Next slide. Now we go to improvement activities. For smaller practices, there are 2 kinds of improvement activities, either medium weighted or high weighted. For smaller practices between 1 and 15 providers, the medium weighted activity is worth 20 points and the high weighted activity is worth 40 points. For the larger practices with 16 or more eligible clinicians, medium weighted activities are worth 10 points and high weighted activities are worth 20 points. The maximum score you can have in improvement activity is 40 points. So depending upon whether you are a small or a large practice, you would have a different choices and mix of improvement activities that you can pick up. And as the QIO, we do have improvement activities that we can assist you with that would help you get to a maximum score of 40 points. Next slide. Advancing care information, also known as meaningful use till 2016. This relates to the use of EHR in your practice. There are certain changes from the meaningful use till last year, and we will guide you through the changes. There is also a possibility of scoring for practices that do not have an EHR, though that's not recommended, but in certain special circumstances, you may get your ACI weights to be lower to 0 with a higher weightage given to quality. Next slide. I'll skip over this because this kind of explains how the ACI, what are the base and performance measures, and we can take that. Okay, so what kind of help is available? Next slide. HSAG, we do offer, as I said, complete service at no cost to you, except in 2 cases. One is if you are a part of a APM, an advanced alternate payment model, then you have to go through the APM. We cannot offer you help directly. And the second exclusion is if you are part of a PTN or a practice transformation network, then there are certain restrictions into the help that you can provide you. Other than that, if you are a provider practicing in the state of California, and if you are eligible for MIPS reporting, we will be able to reach out to you and offer no-cost assistance. How does that work? Next slide. I would recommend 2 things. Either go to our website, which is hsag.com/QPP. Once you go there, you'll find these 3 links. Enroll. Clicking on the enroll brings you to an online form where we capture certain initial data for us to evaluate where your practice readiness for MIPS and offer tailored assistance. Or you can call us at the 844, which is a toll-free number. This number is manned from 5 in the morning till 5 in the afternoon, Pacific time. We have live agents on the queue. And anytime you call us, chances are 80% or more that you will get connected to a live agent. If you are not, go ahead and leave a callback number. Internally, we have a metric of getting back to all voice messages within 1 business day. Or you can always email us. If you email us, somebody would get back in touch with you, again, within 1 business day. The last option is a self-service. There are certain tools and resources available. So if you click on that, you can do your own research and do your own analysis. But my recommendation is to go through the enrollment process first, as it just speeds up the process and allows us to evaluate your practice readiness and assign you to the proper technical staff. Other than that, Sonia at the CAFP has my contact information. You are welcome to either call me or email me directly, and we will be happy to help reach out and help you. Again, this is a no-cost assistance. This is through a federal program, and we will be helping you reach your goals with the minimal effort. And I will hand you this back to you, Sonia, in case there are any questions.
All right, thank you so much, both Leah and Dave, for your presentations. I'm just going to fast forward through this to get to your contact information. Before I go into some questions that I have here, I just want to give you both the opportunity to maybe talk about some highlights that you might want to mention as you've been working with providing assistance to physicians. Dave, I know you've been, this HSAG has been open for a while, giving technical assistance. I wonder if you have any highlights for our members who are on the line, either to apply or just to keep in mind as they move forward trying to prepare for MIPS.
Yes, absolutely. So I think my first response to that is the program, I think, unfortunately, has been interpreted to be very complex and daunting, and people are kind of scared with all the acronyms, you know, MACRA, QPP, MIPS, APM being thrown around. It is actually very simple. Especially if you have done PQRS and meaningful use in the past, you will find that it really maps right back into what you have been doing. And in some cases, it's actually been easier to meet the objectives as compared to meaningful use or PQRS of the previous years. The second takeaway here is that In the meaningful use arena or the PQRS arena, the measurement was based upon the quantity of data and not quality of data. In essence, in meaningful use, you have to meet those 10 objectives. If you meet all the 10 objectives, you're considered a success. If you meet 9 out of the 10 objectives, you fail. But under the MIPS program, it's a scoring-based system. So the better you perform, the higher your score is. It does not reflect on how many measures you passed, but it reflects what is your compliance for each of the measures, and you're scored accordingly. And for the 2017 transition year, there are certain elements that CMS has introduced which makes it really very easy. If you're really in a situation where you cannot participate at all, I would recommend doing the test option, which is just submitting one data set. Very easy to do, a couple of days worth of effort. And the net result is it saves you straight away 4% of your Medicare revenue for the year 2019. So is not participating an option? Well, it's your choice, but it's definitely not an option because you would just be losing yourself 4% of revenue for no reason at all. So other than that, any questions, I think it's very easy to participate in. You can reach back to us and we'll help you guide through the process.
Thank you. And Leah, same to you. Any highlights as you've been working with physicians, maybe that you want to just specifically mention that you already might have gone through in your presentation?
I wanted to clarify one thing. Dave and I are both very familiar with this program, and we talked about the options for the transition year of 2017 and talked about submitting one quality measure. And then Dave in his presentation talked about submitting 6. So again, want to emphasize that this first year you have these different options for reporting. One is to test things out and report 1. The other is to kind of more fully participate, and that requires you to report on 6 quality measures. But you only need to report for 90 days of the year. And that would mean starting by October 2nd of this year. Start measuring yourself by October 2nd of this year. There is this other option of reporting on the full year. But just wanted to clarify in case there was confusion about that 6 measures versus 1 measure. And just reacting to Dave's presentation, I would certainly contact HSAG and I would ask these questions of them. What of these different reporting options should I choose? Should I test the program or should I report for 90 days would be my first question. Should I report as a group or should I report as an individual as a second question? What mechanism should I use? Should I use my HR? Should I get a qualified clinical data registry? And then finally, and I think where they can really offer a lot of help is what metrics to choose in these 3 different performance categories. What quality metrics, what advancing care information metrics, what improvement activity metrics should I choose? So I think that's where they're really going to support small and rural physicians. And I want to highlight that in one of our earlier conversations with Dave, he did say, it encouraged people to contact us sooner rather than later because we have more availability right now. So assuming that, there are 600,000 or so participants in the MIPS program nationally, people are going to need support for this. When we get closer to October 2nd, there will probably be sort of a rush. But best to contact them soon. Use the summer, get in touch with HSAG and start thinking about these issues now. They might have more opening to assist you right now. So I think that there is some urgency there.
Absolutely, Leah. I completely agree. As we head towards the really the drop dead date of October 1st, we are going to get pretty busy. So the earlier you contact us, the better it would be for you, and the more time you would have to work with us.
Thank you. Thank you, both of you. We have a couple more minutes, so I'll just go through a couple of questions that we hear sometimes from our members and just kind of on the web. I know you had already mentioned that they can look up whether they're in MIPS or not on the Lookup tool. I don't remember if you had mentioned if anybody can report on their behalf. I know that this is not something that might be common in small and rural practices, but can people report on their behalf of the practice?
I'm not sure when they say, can somebody else report on their behalf, what exactly it means. The provider has to report the data. The data has to come from the provider's service that they are rendering and recording in the EHR or however they are choosing to report the quality measures. If they choose to report through claims, then obviously the biller can put that into their Form 1500. And in terms of a attestation website, usually the attestation technically, so far we had seen in meaningful use, if it is a group practice, then a group authorized representative can have the login.
Thank you. And then, will this performance data be made public? I don't think this was mentioned in the presentations, but it's, I think, good for our members to know whether or not this is going to be public information.
Yes,
there is certain... Sorry,
go ahead.
No,
the answer is yes, ultimately, that CMS has this CMS Compare website, and the plan is certainly to make this information available to the public, and I think that's really important for physicians to know. For the first time physicians are in the MIPS program, at least they're going to have an overall score, a composite performance score that CMS in the future intends to make public. So a way of comparing one physician to another. So that's definitely part of the plan here, and physicians should ready themselves for that.
Dave, did you have anything to add to that?
No, I was just going to say the same thing, that yes, eventually data is going to be made public.
Okay. All right, thank you. And then, I have one last question, and it has to do with a hardship exemption if they don't have a certified EHR. Is that still in play here? And if so, is there a way physicians can apply for it if necessary?
Well, hardship exemption for the MIPS overall? No. For any provider that sees Medicare patients is part of MIPS, unless they're a low volume provider, in which case, and the very first year Medicare business, in these two cases, they do not have to report to MIPS. Other than that, they have to report to MIPS. They obviously have a choice of not reporting to MIPS, which straight away takes them to the maximum negative payment adjustment. However, there is a hardship available only for the ACI meaningful use portion, which is related to the use of EHRs, but it is available only under certain restricted cases, which is totally outside your control. So if a provider does not have an EHR out of choice, no, then that's not a hardship exemption.
Again, just to return everyone to those slides where we talk about the limited internet connectivity. If you live in a place where there's limited internet connectivity, that can get you out of having to report in the advancing care information category. But you have to apply to CMS and get their, approval. otherwise, I'm not aware of any hardship exemption in that category or any other.
All right, thank you. Thank you so much. I think that actually was the end of my couple of questions. If anybody has questions on the line that they weren't able to ask at this presentation, I think as mentioned, you are of course able to contact either Leah, Dave, or myself at CAFP. We will give you all the contact information in my follow-up email along with the slide deck and point you towards our website that will house the primer and eventually will house the recording of this presentation itself for you to view again. So unless you guys have any closing thoughts that you want to send out, I think we will end for today and just look forward to our email coming up.
Thank you, Sonia, and thanks everyone for participating.
Thank you.
Thank you, everybody.
Bye-bye.